And we're going to talk about ankles. We're going to talk about AP, lateral, general medial lateral, but again, you can shoot them lateral medial, the same verbiage that we talked about before, you may see on the test. More consistently, get lateral and lateral medial, but medial lateral is what we generally shoot. Then we're going to talk about two different obliques and what we see on both of those. They're both going to be internal obliques. Okay, so don't confuse that. It's not, everything else that we've done so far have been internal and external obliques. And both of these are going to be medial rotation. There's just a degree of medial rotation is going to be different. Then we're going to talk about stress views and how to accomplish those and who provides the stress on them. So with AP ankle, again, tabletop, you can do it on the stretcher with a portable, or you can put them on the table, whatever it is that you might want to do. It's up to you. Just extend the leg in this case. So a couple of things on this. At some point, at least one of y'all are going to try to shoot a foot with the foot dorsiflex like this. What are you going to see on a foot in this projection with a central ray coming down like that? You're not going to see anything. Okay, are you going to see the foot? Yeah, you're going to see the foot, but the foot's going to be all superimposed on itself. Okay, so a foot is always going to be, like so. And look at the shadow of this thing. If I can make it stay, you're just not going to get it, right? So ankles, yes, we're going to go in like that. We want the foot dorsiflexed to 90 degrees if at all possible. Now, previous editions of the textbook said that if you don't get the foot to 90 degrees, then what you're going to have is the calcaneus inside of the talotibular joint space. So since the joint is formed by the talus and the tibia, primarily fibula on the lateral side, that's what we refer to as the talotibular joint space, also referred to as the mortis joint. Okay, so you can see how that could pose a problem, right? We've got AP here. We don't dorsiflex a foot, we can get the heel in it, right? So your patient, I can tell you from experience, I've got bad ankles. I've twisted them really badly all my life, but it's going to be very painful for the patient to get their foot into 90 degrees dorsiflexion. And previous editions of the book have said that if you don't get to 90 degrees, then you're going to have that in the joint space, and that's quite a bit of plantar flexion there, right? So I was kind of glad to see in this edition of the textbook that they made the distinction that some degree of plantar flexion is not really going to interfere with joint space. So if you certainly try to talk your patient into getting to 90 degrees, just to make sure that you check all the boxes, try to get it to 90 degrees. But if you can't, and you've got a little bit of plantar flexion, it's really nothing to get in too much of a twist about. Okay, you don't want them pointing like that because that's going to mess up the whole thing. Get them to dorsiflex as far as they can, and then don't sweat just a little bit of plantar flexion. Okay, so plantar flex foot, we want to get about a third of the tib fib because that's where most of the fractures are going to be. Most of the fractures are going to extend from about here down to here. So about a third of the leg, plantar flex, central ray to the middle of the malleoli, which just means middle of the ankle, into the ankle joint. Okay, so your AP, pretty simple, column 8 and all that. And we've got two obliques. One's a 45-degree oblique, and this never really works out because we're not dealing with real human bones put together real well. But I want you to see what happens between the fibula and the tibia as I rotate this guy in. So you got some superimposition over the distal portion, right? And as I rotate, then you can kind of see how some of it disappears, right? We've got a little less superimposition once I get to about 45 degrees. Can you kind of see that? Mm-hmm. Okay. All right, so at 45 degrees in human anatomy, then what you should be able to visualize is, and you can see maybe looking at this and not the shadow, you can maybe see how the fibula kind of tucks back in on the back side of the tibia. At 45 degrees, you should be able to de-superimpose those. Internal oblique, keep the foot dorsiflexed as best the patient can. Internally rotate to 45 degrees, and what you get is a de-superimposition of the tibia and the fibula. That superimposition goes away. Okay, so if you're interested in seeing the lateral malleolus, your obliquity is 45 degrees. Okay, but as we oblique up, let's kind of cinch this up a little bit. As we oblique up, look what happens to the overall joint. All right, so we've got some superimposition there, right? And as we oblique up, we're going to get the superimposition might disappear to a point, and then we're going to get superimposition on the medial side, right? So if you're interested in seeing the talus joint, it's still going to be internal rotation, but it's going to be 15 to 20 degrees internal rotation. It's important that whenever you're talking to the patient and trying to get them to do the rotation, that you just put your hand on their knee, maybe right above their knee on their thigh, and tell them, I want you to rotate your toes, right? And show them rotate, because what's going to happen in a lot of cases is you tell the patient, I want you to rotate your toes, and they're going to go, eh, like that. I want you to point your toes inward, is probably what you're going to say, because, you know, patients are crazy, and if you tell them to rotate their toes, they might start doing crazy things with the toes. Point your toes inward, and in a lot of cases, because the ankle has some movement, you know, they'll just move it, and no rotation at the, you know, ankle joint actually occurred. So put your hand on their knee and say, I want you to rotate from the hip internally, you know, turn your toes in, right? So 45 degrees is going to give you the ankle, but the lateral malleolus, free of superimposition. So if you want to see the lateral malleolus, 45 degrees is your rotation. 15 to 20 gives you the mortis joint. The mortis joint is that joint all the way around the talus. So you should see the talus without superimposition at 15 to 20 degrees, and the lateral malleolus without superimposition at 45 degrees. Okay, in both cases, your central ray is going to be the same spot, right in the middle of the ankle joint, middle of the malleolus. So, lateral ankle, again, just like a lateral foot, in this case, again, the only difference is going to be central ray location collimation. Dorsiflex the foot to a right angle if at all possible. And in this case, our central ray is going to be perpendicular to the ankle joint, entering at the medial malleolus, providing you're shooting medial lateral. But what you want to make sure that you do is open your collimator to include the head of the, actually it's the base of the fifth metatarsal. So, let me see if this is in the book. Yeah, if you flip over to page 320, and I want to show you some images here in a bit. If you flip over to page 320, you find, and I put in the notes, this is Bennett fracture. This is a Jones fracture. What you'll get sometimes with a ankle injury is that tubercle off of the fifth metatarsal will break off. All right, so if they ordered a foot and an ankle, they'll catch it. But if they only ordered an ankle, you may send the patient home with a broken foot, right? If you don't open your collimator enough to get the base of the fifth metatarsal. Okay, so make sure that you include that much. And it's, you know, you're looking at an inch worth of open collimation. It's not radiation exposure for unnecessary radiation exposure in that case. So make sure that you include that in the event that the patient may have a Jones fracture. And Jones fractures, they're graded 1 through 3, depending on where the fracture is. It may be kind of like an avulsion fracture. It may be like what you're seeing here, where the entire tubercle is broken off of it. Okay? Oh, one other thing. Back to the syndesmosis. highly, highly unstable ankle fractures, probably the most unstable fracture I've ever dealt with, or this particular type of fracture. So what you've got again is kind of like a compression sock that goes all the way up and down, holding these two bones, you know, relatively together. And you got these all over your body. You got syndesmosis going up and down your spine to keep your vertebrae stacked on top of, bless you, stacked on top of each other. You got them in a lot of different places. It's not unique to the tib fib. But sometimes, it's pretty rare, but I've seen it 3 times. Sometimes what'll happen is that you'll get a violent twisting of the ankle. Patient steps in a hole or something. You get a violent twisting of the ankle and you don't have any fractures of the ankle, but it's clinically an ankle fracture. What happens is that you rip that syndesmosis from the ankle all the way up to the knee, and the fracture is actually a proximal fibular head. That's where the fracture actually takes place. And by highly unstable, what I mean is that in a normal ankle fracture, you know, you ask the patient to pick their leg up so that you can put the image receptor underneath them. Say, I need you to lift your leg. And they pick their leg up, and the ankle comes with them. And with this type of fractures, what we refer to as a Masseneau fracture. And it's a French spelling. It's in the notes. I'm not going to butcher it up here. It's got way too many vowels. I think a U and an X and all kinds of stuff. A Masseneau fracture. And what happens is as they pick the leg up, the foot doesn't come up with it. It immediately dislocates. If you have their ankle in your hand, you can feel it, you can hear it, and you can see it. So what happens is you go to pick it up and it goes ka-funk. And the leg is up, but the foot just immediately plantar flexed and it's laying flat. And you go to set it down and it goes ka-funk and it goes back into place. Never seen anything that dislocates that easily except for a Masseneau fracture. If that's the case, you may see that sooner or later. You have somebody who, you know, it's that unstable. It's a good idea to go to the doctor who ordered it and say, I think you're missing something. I think we need to shoot this, at least the AP all the way up to the knee, because that's where the fracture is going to be, is at the knee. You're not going to see any fractures. So again, I saw this 3 times, 2 in the ER, and 1 was a patient up in the room, and there's a young woman, and she was getting ready to go to surgery to repair this thing, right? And the tech went up to take the x-ray. You know, she was in a splint. And what is the rule for splinting?
Don't take it off.
Don't take it off. Don't take it off. And guess what they did?
They took it off.
Took it off, right. So they took it off and took the x-ray, took it back down. You know, the doc was wanting to just, you know, check and make sure everything was looking good. Took it back down, developed it, and fortunately, the surgeon came in not too long after that. But that fracture was so unstable that, you know, they put the splint back on, but it compromised blood flow. Mm-hmm. And her foot was already purple, right? So another hour, she would have lost that foot. So 2 lessons from this is, one is, you know, the instability of this particular type of fracture. That's number 1. Number 2 is don't take the splint off, right? This was a 16-year-old kid. Can you imagine being 16 years old and suddenly you're, you know, lost a leg? So we already talked about the AP obliques. Remember, 45 degrees gives you the lateral malleolus. 15-degree oblique is our mortis joint. So you might not even see oblique or anything in the test question referenced. It just may be, you know, how do we see the mortis joint? Your answer is? Yeah, 15, 20 degree internal rotation of the ankle. Okay, so stress views, kind of rare, but what they're looking for is, again, ligamentous damage and how stable is the joint space. So what we'll do is our part in this is just to make the images. So you see on page 327, you see what looks like a piece of tape around the patient's ankle. And what the patient would do is pull in one direction, would make an image, pull in the opposite direction, would make an image. So our job is not to provide the stress. You know, if the doctor says, you know, I need you to shoot stress views, your answer is, are you coming down to do that? Right? So you're not providing the stress views because you, at that point, you're clinically manipulating an injury and your insurance doesn't cover you for that. All right? So you can have the patient do it, right? Just tell the patient, do the best you can to your ability, pull in one direction, pull in the opposite direction, and we're going to take 2 images. Or if the doctor feels like somebody else needs to do that, the doctor's right, somebody else needs to do that. You don't, okay? So have a doctor come down and do it. You just don't do it. So common fractures, you got the Jones fracture I was talking about before. Make sure on your ankle you open it up wide enough that you can actually see the base of the 5th metatarsal. I think I've got some other ones in here somewhere. Let me take a look. There we go. Yeah. Jones fracture, again, just kind of get this, make this bigger. Well, that didn't do it. There we go. So, so they're graded on exactly where the fracture is. You know, I think they give a 1, 2, and a 3, but stress fractures tend to be there. You got Jones fracture and just an open avulsion fracture there. So that's how you feel every single time you kick that door frame. Even if it's not broken, that's exactly how you feel. But that's pretty indicative the patient's got a fracture going on. So broken sesamoid bones, you can see what almost looks like 3, but that one's just broken in half there. So what they'll have to do is they'll have to go in and probably remove one of the fragments of that. So I don't know that this is truly, I think I've got that labeled as a aviator's fracture, maybe, but I've seen something similar to this, and it was caused by a high impact collision, and it was truly an airplane crash. So this man and I think late teenage boy were flying an airplane, lost power, and they had to crash land. And what happens in these cases is either the tib fib goes through, essentially through the talus and the calcaneus, or on impact, the feet kind of abduct and it misses the talus and calcaneus, and they go, you know, just straight through the skin, in this case, through the skin at the bottom of the foot, or through the ankle. So where the ankle should be. So anyway, very nasty, nasty fractures. We spent hours trying to fix that kid's ankles. So you got malleolar fractures. That will be what we refer to as a bimalleolar fracture. This one, this oblique here, is not a full 45 degrees. If you can kind of follow the contour of the tibia, you see where it kind of tucks in behind the fibula. There, I guess it's really on top of, but anyway, you got superimposition there, so it's closer to a 45-degree oblique than what it is a mortis, but you're kind of, you know, somewhere in between. But you got a definite fracture line up in here. You got that definite fracture right there. The syndesmosis is not disrupted. If it was, then that screw hole right there would have a screw going all the way across to the cortex of the tibia. And here's the masseter fracture. So masseter fracture again, and when I tell you, you know, I've spent my life twisting my ankles. When I roll an ankle, I'll bruise all the way up to the knee. I do it well. I do it well. So, you know, I'm messing up my syndesmosis every time. It's just more flexible than most, I guess. But you see where the fracture is there, highly unstable ankle, just nasty. All right, so any questions on those? All right, then, so anatomy of the leg, you got two bones, two long bones, tibia and fibula. In my experience, most of the compound fractures I've seen have been tibia and fibular fractures. So I think that's because, I think for a lot of different reasons, but I think part of the reason is because of the relative thinness of the tissue on the anterior portion of your shin, right? Relatively thin, easy to poke a bone through. So anyway, second largest bone in the body. The fibula is primarily stability for the tibia. And sometimes what you'll see is that if they need to harvest bone for like spinal surgery or something like that, sometimes they'll take it out of the fibula. So once in a while you see a patient with what looks like an incomplete fibula, what they've got is a bone plug that's taken out of the middle of it. It's kind of weird considering its stability, but as long as that syndesmosis is there and proximal and distal ends are there, it remains relatively stable. And they can take a bone plug out of the middle of the fibula.
It doesn't grow back?
Nope. Pretty wild. Just walking around with incomplete fibula. So the small portions that we have to consider on the tibia is the tibial tuberosity. That's that thing that sticks out directly in the front. In young kids who have, knee pain, consistent knee pain, persistent knee pain, if they've been involved in sports especially, or if they're just really active kids, then that can kind of avulse a little bit, and that's what we call Osgood Schlatters. And then we've got two condyles, medial condyle, lateral condyle, and then we've got a tibial plateau, just like, you go to mesas of West Texas and the mountains are flat on top, right? And that's what we call a plateau, right? So it's tibial plateau, and then you've got these little spikes here that are the intercondylar eminence. Now you're going to go through your textbook and you're going to look at all the ligaments that go through there. You appreciate ligaments and all that. Don't spend any time studying that. Those penguins you don't need. So just stick to the bony anatomy at this point. Okay. All right, so we already talked about the distal end and all that. Apex all the way at the top. So the knee, so what we've got is the femorotibular joint space is the knee joint. Significant things at the knee and the distal portion of the femur is that you've got the condyles. Remember, the condyles are your articular surfaces. So you've got condyles, and then you've got the epicondyles, and the epicondyles are those things that you can feel on either side of your knee. So they're going to play a part in our leg and in our knee positioning. And then we've got the patella being the biggest sesamoid bone in your body. The apex of the patella is at the bottom, okay? So you tend to think of mountains and things like that. The apex is at the top, the apex of the patella is at the bottom. So our central ray positioning, if you look at this, if we're looking for the knee, then our central ray positioning is going to be just below the apex of the patella. Oh, the joint space between the femur and the patella would be the femoropatellar joint space. Mainly a hinge joint, patella, femur. So femur, we're not really going to get into the femur just a whole lot, but in the femur what we've got is we've got the head up here, and that's the ball portion of the ball and socket joint. So in our pelvis we've got what we refer to as acetabulum, and acetabulum is the socket portion of it. And just below that we've got the neck, and we've got a greater trochanter. And again, if we're going to have a greater, we're going to have a lesser trochanter. Down here, our hip fractures tend to be one of two types. All right, so we've got femoral neck fractures, which require, in most cases, what we refer to as a percutaneous pinning that we'll talk about probably next week. And probably the more common is what we refer to as an intertrochanteric fracture, and it goes down that intertrochanteric line, that dark kind of highlighted area right there. So how they repair each of those depends on where the fracture is, where the actual fracture is. Most common hip fracture is probably going to be your intertrochanteric, in which case they're going to put one great big fat screw all the way up into the head of the femur, and then they're going to put a plate down the lateral side of the femur with screws going across. If we have a patient who has like a mid-shaft fracture of the femur or the tibia, either one, your repair of that fracture might involve what we refer to as an intramedullary rod. So what they do is they go in and hollow out the medullary cavity. It's just like a flexible drill with a great big head that just goes in there and destroys all that fatty marrow, and they drive a rod down in between, inside the medullary cavity to join the two pieces back together again. They'll put plates, or not plates, but screws at the proximal and distal end to hold everything together. So when you go to surgery, that is the nastiest surgery you will see. And it's fascinating, but it's a bloodletting, it's loud, so prepare yourself for it. Eat something, you know, and the general rules of surgery is if somebody tells you to sit down, immediately, right? So just keep that in mind. It doesn't sound like surgery in there. It sounds like somebody's taking dents out of out of a car, essentially. Because it's metal on metal, banging, blood's flying everywhere. So anyway, on the distal portion of the femur, on the posterior surface, you've got what we refer to as the intercondylar fossa. So it's popliteal surface, the back of the knee, everything else we've already talked about. Okay, so now we're getting to, once we get to the knee, you may have to have the patient take their pants off, put a gown on them, have the gown available, have them lower the pants, keep them covered, but it's kind of hard to roll, unless you're wearing bell bottoms or something, it's kind of hard to roll pants legs up high enough that you can get them completely out of the way. So keep that in mind. Everything else is pretty much the same. If it can come off the patient, if it might obstruct the view, then it needs to come off the patient. At this point, I really kind of recommend that you get the patient on the table. Now, you're probably getting thick enough you need a grid, so I'd recommend putting the patient on the table. So leg, all right. Again, the leg is probably the most common thing that I've seen that's been a compound fracture. So keep that in mind. If the leg, if the bone is sticking through the skin, the last thing that you want to do is draw it back inside. You don't know what kind of bacteria is on, that bony fragment, so you don't want to reintroduce that. If they've been in a high-speed collision and maybe the fracture is a distal end, right? Maybe they've been in a car wreck and they have some sort of compound fracture that went through the skin around the ankle, that's probably come in contact with the floorboard of the car. So what's on your floorboard? Is yours as nasty as mine? So you definitely don't want to pull that back in, right? So be very careful with, tib fib fractures. Sometimes you walk into the patient's room and you can tell clinically that the patient's got a broken ankle or a broken tib fib because their knee is pointing straight up and their foot's pointing that way or that way. So there's obviously a problem there, right? So the positioning that we're going to talk about is for a patient that does not have a fracture, right? So maybe it's follow-up. If the patient has a situation where the the knee's pointing up and the foot's pointing in the opposite direction, then really what you're going to get is you're going to get an AP of the knee and a lateral of the ankle, and then you're probably going to shoot cross table. You're going to elevate it a little bit, shoot cross table, and now you're going to get an AP of the ankle and a lateral of the knee. Okay, so even though this says, the positioning for the tib fib is going to be with the foot pointing straight up and the femoral condyles parallel to the image receptor. You walk in and you see that thing going on, then you're not going to be able to perform that. Okay. If they have a compound fracture, you can see the bone, then just be real careful if you have to elevate it and put it on a pad to get your cross table. Make sure you don't pull it back in. If you pull it back in, you introduce that bacteria. It's got dirt. You can actually introduce a dirt embolism. That would be bad, right? So just be real careful with it, right? So the views that we're going to do of the leg will be an AP and a lateral, typically medial lateral. If you're shooting cross table, it may be lateral medial. All right, so the other thing is that what we need is two things. One is an image receptor that's big enough to include all the anatomy, right? So most of your image receptors in the table are going to be at least 14 by 17. You may have some image receptors that are like 17 by 17. That's great, but like we were talking about on, the forearm, is that if I tried to shoot my forearm on this, I couldn't get it all, right? But if I turn this like that, I'd be more likely to get it all. I probably wouldn't in this case, but I got more room, right? So with the tib fib, you can actually shoot it on tabletop. Once you get to the knee, probably need to be in a bucky, but you can do tabletop with the tib fib. And if you need to, turn your image receptor catty corner so that it's going across from corner to corner. Because you need to include at least 1.5 inches, maybe 2 inches beyond the joint space on each end because of the divergence of the central ray. If you put your central ray just to the surface and the skin surface of the anatomy, it continues to diverge and you might project anatomy off of the image receptor. Okay, so you need at least 1.5 inches, maybe 2 inches beyond the anatomy on both ends. So make sure your image receptor is big enough, catty cornered if you need to. Also, your light field might not shoot a broad enough beam at 40 inches. So you may have to increase 48 inches in order to get that, okay? So collimate ends certainly side to side, but make sure that you've got 1.5 inches of collimation, 1.5 inches of image receptor on both ends to make sure that you compensate for that divergence of the central ray, okay? So now, again, assuming the patient doesn't have an obvious fracture, you're going to lay the patient flat on their back. Pelvis without rotation is probably less important, providing they can do all the other stuff. But if you lay the patient flat on the back, you're more likely to get no rotation. Femoral condyles. So you can feel the femoral condyles. It's the knotty things on both sides of the knee. Have those parallel to the image receptor, or you may see it referred to as equidistant from the image receptor. Equidistant just means equal distance from, right? Equidistant or parallel to the image receptor. So dorsiflex the foot, if the patient can do it, and the toes need to be pointed pretty much straight up. And then your central ray is going to be just to the middle of the anatomy. So if we're looking at 90 degrees from each other, and this is a perfect patient that we're talking about, femoral condyles parallel to the image receptor for the AP, what are they going to be for the PA? Perpendicular. Dorsiflex foot, turn the patient over, under their lateral side. Dorsiflex foot, perpendicular to the image receptor. Everything else is identical. Central ray to the center of the anatomy. Catty cornered across the image receptor if you need to do that. Obviously, if you've got a pediatric patient, their leg is that long, you don't need to put them catty cornered on the image receptor. All right. So again, you know, your leg fractures, they tend to be kind of pointy, you know, so be careful with the patient's leg. You know, you got bayonet fractures, spiral fractures, whatnot. It's like a young patient where the growth plates have just sealed up. So your Osgood Schlatters, what you'll see is the tibial eminence kind of points outward instead of being just a little bump. It'll be knee sticking out. So we've got a lot of things on the knee. We probably won't get all the way through the knee, but we've got a lot of things to talk about on the knee. So we've got an AP, and it might be AP axial depending on the patient. We've got lateral, we've got weight bearing. I missed something in feet. Okay, so in foot, sometimes we do weight bearing too, and this, you know, won't take but a second. But with weight bearing feet, what we're looking for is longitudinal arch. How flat footed is the patient actually? Okay, so and you'll see this in some of the doctor's offices when you rotate out to the doctor's offices. What they have is a box with a slot in it so that you can put the image receptor down in the slot. The patient stands, you know, on that box, and you just shoot a lateral foot. It's just weight bearing. Their weight is provided by their body. You know, they're not holding weights, it's just standing up. And it's weight bearing lateral to evaluate longitudinal arch. Okay, that's really pretty much all you need to know about that. But we're going to do weight bearing here as well, and we're going to do 2 obliques, and then we're going to do some specialty views for the intercondylar fossa. So for the AP, all right, so AP, have a patient lay down flat as they can get, fully extend the knee, and we want, just like in the tib fib, we want the femoral condyles parallel to the image receptor. Now some people will say, well, look at the patella, you know, look at the kneecap and put the kneecap right in the middle. And in a lot of patients, that's okay, but a lot of patients have kneecap patellar tracking issues, so that the patella might not be directly over the center of the femur, okay? So it's better just to get put your hands on the femoral condyles and try to get them parallel to the image receptor. Now here's where it gets tricky. All right, so we've got 3 different possible angulations. So if the distance from the patient's ASIS, that's a pointy thing that sticks out of the front of the pelvis, ASIS to the tabletop measures below 19 centimeters, then you're going to angle 3 to 5 degrees caudad. If it's between 19 to 24, we're going to angle perpendicular. If it's 24 or above, we're going to angle 3 to 5 degrees cephalad. Okay? A lot of numbers there, right? So, and a couple of other things to consider as well. All right, this is distance between the ASIS and the tabletop. Okay? Does that say anything about hypersthenic, asthenic, or anything like that? No. Because we've all seen, he's never going to watch this, so I can say this, but my brother-in-law is hypersthenic. The man, he's well over 400 pounds, and it's all gut. But you could plumb a wall with his butt. He has none, all right? It's flat as it can be, okay? So he's hypersthenic, but that distance may not be reflected in this. Okay, so take a look at the patient. How thick, fundamentally, is their butt, right? So if they got back, then they're going to be down here, right? But if they don't, they're going to be up here. All right, so look at them, and the way you can see this sometimes is just by stepping back and at what angle is their femur, right? If it's fairly well parallel, then they may be up here, right? But if they got a big steep angle, then, you know, we got this thing going on. And what you remember then is you got to remember 3 to 5, but what you remember is 19 to 24. Anything below 19 to 24, angle. Yeah. Anything above, cephalad. Okay. So 19 to 24, perpendicular. Anything below 19, you're going to angle 3 to 5 degrees caudad. Anything above, you're going to 3 to 5 degrees cephalad. Some of your old techs might want to throw that on every one of them. How are you going to change it? You're not. Exactly. You're not. All right, so, and then it enters half an inch to an inch below the apex of the patella being at the bottom, right? Okay, so it should look like that. In this case, the patella is right over, the distal portion of the femur. Joint space is open. If your angulation is wrong, and it's maybe not perfect in this case, then what you're seeing, can you kind of see how you've got a density here, and then you've got another density back here? What you're seeing is the anterior and the posterior portion of the tibial plateau. So your goal in that angulation is to put the central ray parallel to the tibial plateau. Okay? So if it's not parallel to the tibial plateau, then that's what you're going to see, is you're going to see, the front and the back of the tibial plateau. You're not going to see just a single line. But notice, you've got superimposition on proximal end, just like what you did on the distal end as well. All right, so lateral knee. Anybody shot a knee yet? I know you can't get a check off, but have you shot a knee yet? How'd you do? How many times did you repeat the lateral? Have not had to repeat. That's great. So the lateral knee is one of the harder things to get perfect. You remember the lateral chest x-ray? You always had a little bit of rotation. Lateral knee is worse, okay? So if you ever get one, and you will, when you get one that has no rotation at all, just give yourself a pat on the back. If you have just the tiniest amount of rotation, don't go back and re-blast the patient. These are hard to get, okay? So you're going to turn towards the affected side, and you want to put about a 20 to 30 degree bend in the knee. And what that's going to look like, patella twisted. That's not good. What that's going to, that's going to look like is something about like that, okay? So if you bend any more than that, or you straighten any more than that, and what you're going to get, I don't know what I've got going on with my patella, is a decrease in the joint space between the tibia and the fibula, okay? So you may see a test question somewhere that says, to maximize the volumization of the tibofemoral or the femorotibial joint space, how much do you need to bend the knee? And that's what it's referring to, is if you straighten it any more than 20 to 30 degrees, or you bend it any more than 20 to 30 degrees, you put stress on that knee that's going to bring those two bones closer together. So maximization of the volumization is what it's talking about. All right? So 20 to 30 degrees gives you the most joint space. Okay? Don't bend more than that, don't bend less than that. So rotate towards the affected side, bend the knee 20 to 30 degrees. You may have to put the patient's opposite leg in front of, or possibly behind, whichever way, the patient's more likely to be less rotated. 20, 30 degrees. If you suspect that the patella is fractured, then you don't want to bend it all that much. More on that here in a bit. So the femoral condyle is perpendicular to the image receptor. It should be superimposed. In this case, you're going to use a 5 to 7 degree cephalic angulation on everybody. And this is why. I think I'm just going to have to take that patella off. There we go. There we go. All right. So as he's a little bow-legged. As I hold this, what do you notice in my femoral condyles? Can you see anything? Let me turn it around this way. Not symmetric. Right. So the medial condyle is a little bit distal to the lateral condyle, right? So if I put the patient straight down like this, now it's even worse. So the lateral, the medial condyle is here, lateral condyle is there, right? So in order to put the central ray parallel and stack those things on top of each other, I need an angulation. No, I just did that exactly backwards. I need an angulation. I need a cephalic angulation of 5 to 7 degrees to put them on top of each other. Otherwise, what you're going to see are the condyles not stacked on top of each other like that, but they're going to be like that. Okay? So where we have a difference in angulation according to, you know, the thickness of the ASIS to the tabletop for the AP, for the lateral, everybody's going to get 5 to 7 degrees cephalic angulation. Okay? Everybody. Going to get that 5 to 7 degree cephalic angulation. Okay? Yeah, it looks like that. You see how they're not perfectly superimposed? You're never going to go back and reshoot that. Ever. Right? That's as good as you're going to get 95% of the time. Okay, so we're out of time. I think y'all have a test today, don't you?